All right. So I'm Rocco Gonzalez. I am the chair of our advocacy committee here for the Midwest Gateway chapter for HIMSS. So HIMSS, long name, Health Information Management System Society. But basically, we just try to be the thought leader of all things health, technology, digital health. And today we're here to talk through the One Big Beautiful Bill Act. So I think it'd be hard to not understand that the name, the OBBBA, that's been a critical part of our society here, really for like the last, I'd say, 6, 9 months. But now we're starting to kind of live into it, right? And through this, really, we wanted to have a multidisciplinary panel just to understand, for the state of Missouri, what does that really look like? Is it going to be positive, negative? Like, what are the specific parts for sure of rural healthcare will be playing a part in either helping produce different things together? So within that, basically just going to show you all the panelists that we have here today. So we have Jane Drummond, who's the General Counsel and the Senior Vice President of Government Relations here for the Missouri Hospital Association. We also have Landon Fulmer, who's a lobbyist for the Kansas Health Association, but also works at Ave Maria Academy as really a prime part of their chair of policy. We have Representative Marty Jo Murray, who works within the District of 7-8. So that's really in the St. Louis City area for our state House representatives. And then Josh Weimer, so our Chief Health Information and Data Strategy Officer for the Missouri Health Data Consortium. And we have a lot of information about them because these are all people that have definitely made a career in doing health policy, doing things within this space. But I want to get us really straight into what we're doing within this panel, which are what is this One Big Beautiful Bill Act going to be doing for Missouri healthcare? So with that being said, let's get into it. The first piece, because I think that there's a lot of, awareness of what is the One Big Beautiful Bill Act. I wanted to start really with the challenges, the concerns, just to get this party started. So within that, and this could be for anyone on the panel, what are some specific healthcare technology challenges that you really think the One Big Beautiful Bill Act is designed to address in Missouri? So basically the positive from what are they trying to improve with that act within the state?
Well, this is Jane Drummond. I'm happy to kick it off. Missouri Hospital Association's been working pretty closely with the Mo Health Net Division as they have developed their application for the Rural Health Transformation Program. And I would say both the One Big Beautiful Bill Act and the Notice of Funding Opportunity for that Rural Health Transformation funding are really geared toward creating better collaborations, better strategic partnerships, better connections between providers through technology to improve patient outcomes. If you look at the text of the bill itself and you look at what's in the notice of funding opportunity, they're really looking at how can we use technology to improve prevention and management of chronic disease, give patients better access to health care, and then follow patients through that journey through technological innovation so that even if you are in a very rural part of the state, you're getting access to the care that you need.
And this is Josh Weimer. So to follow up on Jane's comments there, this is about outcomes, this is about access, this is about accountability around, the productivity and efficiency in healthcare. And I do see them leaning in. The language is very explicit to lean into the use of technology. But it is interesting because it's forcing us down that path. Redetermination every 6 months for Medicaid, et cetera, is a profound burden, I think is the lightest way to describe it. And, this has a ripple effect all the way through every layer of the payer and provider communities because of the need to, we want those who are eligible to be eligible on a continuous basis. So especially front and center, and thanks Jane for calling out Mo Health Net and social services. This is a top concern because not only does it lean into technology in a positive way, but it also makes us very dependent because in the case of redetermination, We're not just going to be able to go out and find 1,800 additional case managers to help accomplish that.
And Representative Murray, please.
Yeah, I think I may be the chicken little of the panel, right? I'm very encouraged when we talk about the advent of the technology, but I think that, from my experience being in like healthcare, but specifically like as a project manager, like I think it introduces a degree of risk, which in general is okay. But when I think the stakes are so high when it comes to it being regards to like eligibility, those systems having to be rebuilt to handle like the new work for the requirements, the cap, the redetermination rules, I think it adds a level of risk. It'd have been nice to have been able to have you know, like a longer runway. Because when I look at just the trends in the industry as far as like cybersecurity, and that just being an added element is just one thing that causes me a little bit of heartburn.
None of that.
And
Landon,
and
anything?
if I could add that one of the relatively unremarked things that this bill does is it makes permanent some key changes to high deductible health plans. It actually makes permanent the telehealth waiver that's been in place. Now it applies to plans that were put in place after December 31, 2024, but it allows for those plans to cover telehealth services before the deductible is paid. So that's going to help. There are a lot of Americans who are getting their health coverage by high deductible health plans. And though this has been in place for a long time, there's going to be a lot of just political roiling over the next year, 2 years, 3 years about which telehealth extenders get extended, which ones are going to go the way of the dodo. Do we have to do a complete recasting of how it is that the federal government addresses telehealth? But this one was made permanent. And I think that's a really important point. So, people with high deductible plans will be able to access telehealth, before their deductible is met without having to pay for it. So I think that's a positive thing in the bill.
Awesome. Yeah, so interoperability is the word. It seems like that seems to be coming up a lot. But then pushing for that technology, it's not so much of a pull method, but a push. Like we basically are having to do these changes, whether or not we like it, or I think to Representative Murray's point, whether or not we have the time to do it. Yes, Josh.
Well, I think this is going to also advance other critical conversations alongside what we do as technologists and as policy leaders, is that, this is going to push the privileging conversation much more quickly over the next year or two. This is going to help us access and provide resources. I think Representative Murray makes a good point. That door, that access to services, when somebody reaches for it, it needs to work. They need to be able to go through it and access the services they want and need. And I think that we know in the under-resourced rural and under-resourced urban areas of Missouri that trust is our number one concern. So the question is, as leaders, how can we help translate this and prevent another layer of challenge in the trust arena to move healthcare forward? Because we know that that's such a vital component for especially these under-resourced communities.
Amen to that. So on the same topic of timing and pace, so you set me up very well. So the second part around really, what do you think are the concerns from the healthcare provider? This could be hospital, this could be smaller rural clinic, what have you, about the pace of the implementation, or I guess the administrative burden tied to the compliance of all like the various things that you've all been talking about. Like, what do you think is really an issue? I think Jane definitely touching on this would be helpful. Like, what are you hearing from your members around as they see all these things? Like, how does it actually get done at the ground level?
I think there are two concerns and are largely two concerns. And one's on the side of, what we've talked about already, which is the state's ability to efficiently and accurately perform those eligibility redeterminations. As Representative Murray said, it would be nice if we had a bit of a longer runway for those, because The state really is going to need to make some investments in people and in infrastructure to update systems to be, it is an administrative burden for the state to have to do those redeterminations every 6 months. Similarly, the state does not track work requirements right now, so they are going to have to figure out how to get systems in place to ensure that people that are eligible for Medicaid are not getting kicked off of the program. And the problem for hospitals when people do get kicked off of Medicaid is, they end up lacking access to care. The one place you can go when you don't have access to care anywhere else is the emergency department. So if individuals don't have access to primary care, to dental care, to all the other things they need, they show up in the emergency department, they are sicker, they are more expensive to care for, et cetera. And so just making sure that the state really makes the investments that it needs to be able to do that adequately and efficiently. And then I think there's just a lot of unknowns about, once this application is submitted by the state for the Rural Health Transformation Funding, what the state is envisioning right now is they're going to split the state in approximately 25 to 30 local hubs that are supposed to sort of collaborate, coordinate care. Our hospitals envision that there's going to be varying levels of sophistication among those hubs. You're going to have some regions where you are already going to have natural partnerships, collaborations. People are going to hit the ground running. They're going to be able to work together. You're also going to have regions where providers are not currently working together, and all of that has to be built. So I think as they look at how funding flows to those local community hubs, I think there are concerns that, some of us may be left behind while other hubs that are of varying levels of sophistication get ahead of us and get the lion's share of the funding. So I think those are some concerns about the pace and the actual implementation. I think one other area is just, this looks a lot like some of the COVID relief dollars, where if the federal government assesses it later and says, we don't really like how this was spent, the potential for that money to be clawed back down the road is a big concern.
Totally. Yes, Josh.
Yeah, and I would echo again what Jane highlighted. The state is taking a very considered approach to this. Even in my role, which with the Health Data Consortium, for those that are unfamiliar, it's a unified effort between social services and MoHealthNet, mental health and senior services. And moving this role during our season of change, shall we call it, in April, March, April of this year, moving this role and recognizing we need to be very strategically focused because the tail on this might be longer than we think. Jane does a very good job of highlighting that there is going to be a continued learning cycle, a feedback loop at the federal level. But we also would be remiss to think that the federal posture would change in the next 11 years. So if we're looking at a longer range fiscal constraint, posture of fiscal constraint, just looking at the tea leaves legislatively, we need to get very smart very fast because of the extra lifts that are in the bill.
Representative Murray.
Yeah, and then one area that was a particular interest when we talk about like how health plans in hospitals will react from a community affairs and community engagement perspective, because I think it puts more of the onus on the system to ensure that people don't fall through the gap. So that's one area that I'm very interested in, particularly when we look at communities who are, whether that be in the rural areas or just more urban areas, but lower income. Like, how do we make sure people who aren't employed at the time, because I think the requirements in the bill also states that they can have like community service of some kind. So I'll be interested to know if like community affairs departments might use that as an opportunity to like kind of rebrand their face with the community.
And I will tell you that there are discussions occurring among, the Hospital Association, the Primary Care Association, the Behavioral Health Council, trying to figure out how can the provider community assist in this, along with the healthcare foundations. I do think this is going to be an all hands on deck type of effort because we really don't want these people to fall through the cracks. So how does the provider community partner with the state to make sure this operates smoothly and efficiently?
And I think to echo that, I think that providers are in a unique position to help educate policymakers on this because, to be quite blunt, the reason that the Rural Health Transformation Program exists is because there were members of Congress who needed to vote for an increase in funding for rural health because of the fact that there were reductions that were being made to Medicaid spending elsewhere in the bill. And so they kind of just created this bazooka of money and they blew it at the states and they're trying to make the rules as they go. And so one of the things, I mean, I've already seen this. Of course, my primary responsibility is in Kansas, and I see this in Kansas, and I assume this is true about many other parts of the country. State governments are looking to providers right now to be like, what the heck do we do with this? And so I think this is an excellent opportunity for those of you who know to be a part of the policymaking discussion. And that will also help with some of these like back end effects where we might end up with uh, the federal government reviewing what's going on, similar to what they did with the CARES Act money, being like, hey, was this spent well? Was it spent inefficiently? Can we claw some of it back? Are there going to be rescissions in the future? The more that we can get out front on that and make sure that the money is being spent in efficient ways that really do help these collaborations in rural areas, it's going to go better in terms of just the general policy making outlook going forward.
Please, Josh.
And if there's one thing we know that technology and the people that run it cost money. And so I think, rather than programmatically feeding this out at a very measured pace, I do think Landon's analogy of a bazooka of cash or money funding is appropriate, and it allows us to dream big, because I think the representative brought up a very important point, which is we have need across the entire state. We have an incredibly diverse cross section of that need. I think Missouri can lean into that, urban, rural, different family structures, the cultures, so many things that are incredibly, I view this as an opportunity, because when we think about specifically the work requirement, and then Representative Murray mentioned, that you can have alternatives to actual full-time employment, regular employment. Imagine the potential for our communities. From my side, I think this looks very different depending on where you're at in the state. But what it does result in is some level, regardless of how you feel philosophically or policy-wise about the bigger initiative, it results in healthier communities from my perspective.
Perfect. Yeah, I would agree. And I would say shameless plug, if anyone's wanting to be more focused on advocacy, our Health Information Management System Society, Midwest Gateway Advocacy Committee would love to have you here. So, shameless plug. Couldn't fight it. All right. Next up, we kind of got there actually, and I think to the good point, Josh, I'll give you 20 bucks after this. When we think of how the One Big Beautiful Bill Act is doing, technically, is the two things come to my mind, especially being the evaluator. What are those metrics of success to say? And we've heard many things, honestly, that would be positive from this act. But what are those specific metrics of success when we look a few years down the road, maybe even like a decade? What do we want to say, hey, this was a good idea because this happened? Anyone's thoughts?
I think one of the
So I,
most, oh, go
go
ahead,
ahead.
Jane, please.
No, go ahead.
I think if
You
we
got
look
it,
at it
Landon.
from a perspective of rural healthcare delivery, it's that there is and I don't even know exactly how we would quantify this, it would probably be done by survey, but that people who live in rural areas understand the continuum of care. Because as we continue to see depopulation in rural zip codes throughout the country, they're going to need to know that first, I find my doctor by telehealth. Second, I make sure that I have access to a clinic and I know those hours. Third, if I have a real issue, I know which hospital that I'm going to. I'm getting directed in the right way, and that all of those touch points will have seamless health information technology that connects all of the telehealth, whatever platform that is, to the primary care physician, to the hospital that they go and they access. I think that If we see in surveys, 5, 6 years from now, that this has become more seamless than what it is right now. I mean, I live in a rural area and it can be challenging trying to figure out where to go, and I kind of know what I'm doing. So, I think that simplification of, at least having some kind of unifying format for how the information moves from place to place will be really edifying for people who live in rural areas.
Agreed. Anything on that, Jane, or anything else to add?
Yeah, so the notice of funding, well, actually the bill and the notice of funding opportunity require that the state establish some performance metrics to demonstrate that as these rural health transformation funds flow into the state, that they're actually working. And I think, I think some of the things that the state is looking at are both qualitative and quantitative. There's a lot of population health metrics that I think we will see increasing. They're going to look at things like A1C, obesity rates, treatment, how many preventative screenings are people able to access? And we've advocated from the very beginning of this process with the state that this whole thing needs to be very patient focused. However we measure this, it really needs to be from the purview of the patient. If building on what Landon just said, if I'm trying to access care, what are the basic needs? Do I know how to get transportation if I need it? I mean, transportation is a huge problem in the state of Missouri. Once I access care, if I'm accessing different providers, how interoperable are those systems? Are they talking to one another, or am I getting fragmented care from different places? So I think the technology piece is trying to provide technological systems that overlay, every provider has their own sort of level of sophistication and what they have in terms of electronic medical records, et cetera. We thought back when the ACA passed, we would be interoperable by now. We're not. So what kind of overlays can we give these providers so they can really start talking to one another and following the patient through not just health care, but access to those other services that they need, transportation, housing, nutrition assistance, et cetera. And I think if we can show that connection that follows the patient all the way through, that is definitely a measure of success.
End of that. Representative Murray.
I certainly can appreciate this question. Because no, it's not a spoiler. I was no fan of this bill. I had no shortage of like yelling at the TV screen as they were debating it. Um, but if I were to think about metrics and like how do we determine success, I think the number one like low-hanging fruit that I will be focused on is like the impacts on the state budget from a balance perspective for Mo Health Net. So seeing like how big that shortfall will be under that 3.5% gap. But then also when I look at the perspective of, kind of like an unwritten measure of success is like, does the amount of individuals who might fall from Medicaid, is it equally correlated to an uptake in like private plans or for like the free marketplace, or are they just simply not having any coverage at all? And are we capturing that expense in the emergency department? So I think that'll be one of the things that I would just kind of be interested from a professional standpoint. And then the other thing I would say is just, um, and I don't know that we would track this, but the closure, like, because the idea is that rural fund, right? That rural health transformation dollars, like I think it was like $50 billion. From the state of Missouri perspective, like, will we be able to utilize that in a way that we aren't shutting down hospitals in rural areas at the rate that we're doing thus far? So I think that'll be one thing that'll be very apparent. And I think what that means for the individual is them not having to drive from outstate Missouri all the way to St. Louis to try to get care. I mean, it's already just the wait time alone. I almost will say I'll be on WebMD before I have to sit in the emergency department. So I just think that from a patient perspective, that's one area that I will be watching.
Well, and just to piggyback on that a little bit, one of the things we haven't really touched on yet are the workforce incentives that are in this bill, and those are hugely important. And that is a metric that we can measure and we can determine: are we recruiting and retaining the healthcare providers that we need in the state of Missouri? And to the extent that we're not able to do that, are we connecting people through telehealth to specialty care? You're right, Representative Murray. I might not be in a position to access specialty care from rural Missouri because I don't have transportation or the wait times are long, what have you. But if I can be in my rural community and at my rural hospital, and I can, through telehealth, access specialty care at Mercy or BJC or SSM, that's extraordinarily life-changing. And so that's another metric, is just determining, are people able to get access to care through these technological innovations like telehealth.
And to build on that too, I think if we're going to etch something in stone, this is being recorded. It'll probably be viewed and over the next months or full year as some sort of an offering. Even a year is intimidating. But if we want to etch something in stone for the length of the funding of the rural transformation, for example, I think I like thinking more macro, even though I am a clinician, even though I am a health information leader, is how do we keep that clinician, that practitioner, that provider, physician, how do we keep that professional in their community? I don't care if it's highly concentrated urban. I don't care if it's the most remote rural. What I do know is that access to care, I mean, I live in the donut around St. Louis. I want the inner city of St. Louis to thrive. And I think that the beauty of what we have is that hopefully we can derive benefit. And what we know is that telework, especially in the context of COVID, was a huge boon to the suburbs and especially our rural communities. What can we do to keep those health providers in the rural and dense urban areas? What can we do to promote and develop access to care? I live in one of the highest concentrations of healthcare in the United States, and I do not access it by walking through a door. So what do we do to democratize that? What do we do to expand those resources and accessibility? And I think the other part would be that pulling that string on the economy of this, which is these funds don't hit us all at once. It's a multi-tubed bazooka that Landon mentioned earlier. Do we spend it in a very thoughtful way around these initiatives? And specifically, can we find these multiplier and enabling investments? And just an example would be expanding the implementation of accredited, integrated, interoperable EHRs. We have success stories in Missouri where, with an initial investment, there's a local public health authority that literally found, because they're able to code now, more than $1 million of revenue a year that is more than sustaining the cost, and it's actually holding positions in place in that county serving that community. So what can we do to find those initial opportunities that require some seed money, but turn into self-perpetuating strengths for those communities moving forward? And I know we have examples of that. I know there's a lot of work going on in the collaboration between the Hospital Association, the Primary Care Association, and the Behavioral Health Council. I've sat in on some of those meetings and heard them working through the metrics of what this looks like for them for success in the months and years ahead. But what I do know is that folks are really looking at this from how do we make the lived experience of every Missourian better? And to me, that's how we know we've succeeded in 2, 3, 5 years.
Josh, you just raised a really important thing for hospitals. And one of the things that we're really looking at as we think through the use of this funding, there are some limitations in the notice of funding opportunity on replacement of EHRs, but at the same time, it encourages all kinds of technological innovations to assist with revenue cycle management and other ways that hospitals capture, well, and other providers too, frankly, capture data from their EHR. So another, I think, measure of success and something that will absolutely help to prevent those hospital closures that Representative Murray talked about is let's get paid better for what we're already doing. The reimbursement system is so fragmented. It is so difficult. I have hospitals that have entire departments that are chasing down denials, appeals, etc. And there's so much artificial intelligence that can be applied to that. And the payers are doing it already. The hospitals are a little bit behind the 8 ball on how they use that AI to enhance their revenue cycle management. So I think we can do a lot to stabilize rural providers by giving them the technology they need to get paid better for what they're already doing today.
I think this also plays into a number of things that still need to be addressed at the federal level. For instance, how Medicare Advantage plans sort of like exist on a denial feedback loop until you fight them. Or trying to open access in a more profound way to critical access hospitals that would like to transition to rural emergency hospitals if they're in an area where that makes sense for them. We don't want to force anyone to do that, but I think that there's some possibilities there that the current program doesn't quite allow for, and we need to make a few changes there. And then also, I think even reopening the question of, talking about this reimbursement issue of, whether or not it would make sense to, open up the necessary provider designation for PPS hospitals to look to become CAHs in the future. These are all opportunities I think that are out there that would require a fair, amount of political will, because you're opening Pandora's box anytime you go into committee and start to peel away at the Social Security Act. But these are things that I think are going to be necessary, and I think are going to be exposed as necessary changes here over the next 5-6 years.
Agreed. Yeah, so I think some themes I'm hearing, one is metrics wise, the health of the community, obviously, the health of the person is critical, but how we measure that could be kind of difficult. But a big piece, also a theme is workforce. So that's really critical. I think both sides, right? No, it's not, it's a non-political issue. How do we expand, workforce opportunities in all the communities that we serve? So thinking through that and how do we just develop that innovation with very unique partnerships, startups, universities, private sector. I mean, I think another theme I heard was we got to rethink who we are, we as in healthcare, government, legislators, and really try to develop that true, I mean, lack of a better term, interoperability between ourselves, between basically disciplines and between sectors. So I'm curious, we all have, if you have any examples of what you are right now seeing with that different innovation, collaboration between those different sectors, or things that you believe need to happen in the future through this One Big Beautiful Bill Act.
I'd like to
Yes.
see us hold on to what we have. I think anybody with a workforce right now is focused on the disruption, trying to sustain their teams. At the state level, what are we going to do in the changing funding environment? How are we going to stabilize let's use the term lived experience again of an employee in healthcare right now, especially in information and technology, as they look to deliver these services and support this change across our state. But also the second part would be, we live in a very sophisticated region from an academic, from a healthcare, from a technology perspective. What are we doing to bring along and upskill and really maximize the resources and those who want to engage from our communities? Because I think when we looked at alternative paths to employment, when we look at the ability to, maybe more non-traditional paths into healthcare at whatever level is appropriate for a community or an individual, we're going to need to continue to maximize the channels to bring people into this ecosystem. Because if we don't, we're leaving not only the patient behind, but we're leaving communities that need these opportunities behind as well.
Definitely. Representative Murray.
This question is one that I would say is certainly I can appreciate because it kind of shifts my focus from more of an optimistic standpoint. And it's been almost, I would say, over a decade since I worked for a company called Advanced ICU Care. I believe their name is High Acuity Health now. And that was like a telehealth solution in emergency departments in like rural areas all across the country, and being able to leverage technology to provide like that quality of care for people who are a little bit more remote from when you think about where the skill for the physicians reside. So I can only imagine where they are now, and I could see this bill kind of forcing the system to find efficiencies in that way, and not just in the emergency department or in the ICU environment, but just even outside of that. You look at the way kind of like the community is kind of leveraging things like smartwatches and like I don't know all the different the the health technology that exists already outside of the system, but how could we kind of integrate that? How could we use AI to assist in terms of like the delivery for care? I think that could be a unique opportunity to reshape how we look at healthcare. So, from a perspective of like the universities, obviously they will be looking at like outcomes and pilot programs. And I think I'm not sure if I'm mistaken, but I believe WashU may have something similar, like in their innovation lab, where they're working on things like that. I know BJC has like a telehealth solution that they have as well. So it would just be interesting to see how the system as a whole just reacts. What other people are doing in other states that we might be able to replicate. But that will make it more for an exciting time.
I totally agree. And I think one of the things that this bill may actually promote is, there's a little bit at the margins going on out there with respect to sort of remote monitoring of patients. And I'm not necessarily talking about just, like a telehealth visit, but wearables, the ability through AI to sort of create a digital twin that then can sort of be monitored through various devices by your healthcare provider. And that's going on in some very sophisticated areas, but I think this has the opportunity to push that forward, to meet patients where they are, and to do a much better job at actually monitoring their healthcare in real time, and getting at that chronic disease prevention, management, et cetera, that we don't do a very good job of right now. I think the other thing that we will see is, this has to be sustainable. The federal government has said whatever you build with this has to be sustainable, because in 5 years the money is going away. So there's going to be a drive towards value-based care. How do we use this money to build things like clinically integrated networks? We have a group of independent hospitals that are looking at that right now. They're standalone, they're not part of a system. How do they create a network among themselves that improves patient care, but also sustains them financially, so they're not feeling, closure pressures or pressures to join a system? So I think there's a lot going on in that space as well.
Any thoughts on this, Landon, before we go to the next questions?
Well, then
Perfect.
I'll just tag on then
Sure.
with what Jane shared, that when we think about health systems at large, their number one thing, at least strategically heading into the last couple of years, was post-COVID, how do we expand our primary care pipelines? How do we, enhance access to our specialty and more cadence services? And I think if we talk about what changes the math, getting every Missourian connected to healthcare, getting every Missourian access and enhancing that trust component, it in a way it does answer the mail for these systems that need to keep the resources, to keep the lights on, so to speak, let alone the providers and clinicians in their spaces. They need the communities to engage with those resources, and I think these there is a path here where it benefits everyone.
Agreed. Yeah, being able to think differently of who we are together, not just who we are by ourselves, I think is a critical theme throughout most of this. So we've talked a little bit about, the good and the bad of it, what we believe we need to just almost like this cultural shift needs to happen within the state around health and well-being. So now looking ahead, and we've mentioned this already at various times, but I'm just curious your all's thoughts because you all either had a part to play in this, the application, or obviously you're aware of the different parts of the grant itself. But we know that there's $50 billion coming with that rural health transformation. And what do you see are like the competitive advantages that Mercy has that either puts us apart from other states or at least gives us that leg up that either we aren't as aware of or things that are right in front of us that deserve to be called out?
So I do
Whoever
know
wants
the
to go
state.
first.
Yeah, I do know the state is building the concept in its application around the Torch program. And if you're not familiar with Torch, it is the transformation of rural community health. It's a pilot in MoHealthNet through the transformation office. They're piloting it through 6 hospitals. And while what they're planning to do with this rural health transformation program is a little bit different, that Torch program was mentioned in CMS's notice of funding opportunity as the types of innovative projects that CMS views as things that they would want to fund through this money. So that is very much a positive for Missouri, that we were sort of like front and center in that notice of funding opportunity. Missouri's already doing innovative things in this space. And so building on that, I think is going to help Missouri's application be very competitive. And that's that sort of hub model that I talked about, where resources get driven down to that community level, so that those communities can determine what are their needs and they can best do care collaboration coordination through the use of the various providers, community health workers, technology, et cetera, to meet the patient where they are. So I think that is going to help us a lot in terms of the competitiveness of our application.
Thank you.
Just
Agree.
remember that some of this money is not going to be allocated competitively.
Right.
Half of it is going to be distributed to each state just because you're a state. And then the other half of it, if you have a larger rural population, there's a scoring system basically, or a larger rural poverty problem in your state, you end up getting, you're going to get more based off of a formula that HHS is going to determine from the text of the bill. There is a competitive component to that, and this is where a lot of the states are zoning in on being able to get funding from that particular component. The reality is that every state needs a plan in order to get any
Mhm.
of the money. But once you have a plan, you will get most of your money. And then there's like that small amount that is going to be competitively awarded by the Secretary of Health and Human Services. So I think that Missouri is in a really good spot, as I think are both Kansas, Arkansas, Iowa as well.
Perfect.
And as we
Yes,
look
Josh.
at, all the interests competing for these dollars across the states, and I want to start with, I think the laboratory of states is going to be very useful here. I think we are all going to learn very quickly from each other in the first year. What is highlighting, where are the successes that can be highlighted? I think federal is going to be very focused in on that. I haven't seen quite as acute messaging before. So I do hope that the federal keeps up this level of engagement from the HHS side and keeps on highlighting, as Jane mentioned, what they'd like to see. Because like any relationship, when you know what the expectation is, you can rise to meet that and hopefully beat those expectations. The second part would be, I think that when we think about the big pot of money, Landon brings up an important point, which is even on the Missouri side, there are going to already be obligated chunks of these funds that go towards the line items in the bill, but also just existential needs that are going to help keep Missouri stable and moving forward for our citizens. So I think understanding that really this conversation is about not the margins, that's not fair, but it really is trimmed down by the fact that there are obligated places to go with this money already, at least a large chunk of it.
Yeah, one other thing I would say, just from a pure advocacy standpoint, we're pretty lucky in terms of our congressional delegation. I mean, these funds would not be in OBBBA if it weren't for Josh Hawley. He was instrumental in getting this fund established. I know we did a fly-in with our rural members back in September. We met with Senator Hawley, and he was going from our meeting to a meeting with Dr. Oz to talk specifically about these funds. Congressman Smith, as chair of the Ways and Means Committee, is leaning in heavily. He cares dearly about rural health care. So I know that he has been talking to Governor Kehoe and other state officials about how these funds will be used in Missouri. I know he's also been talking to CMS. So we have great advocates within our congressional delegation who have the ability to influence not how competitive Missouri's application is. They're sort of like serving a liaison purpose where they hear from CMS what CMS is looking for. They're communicating that to the state so the state can better its application. So we're really lucky in that regard, in that our congressional members are very engaged on this.
So last piece, like I said, we don't have magical wands here. And HIMSS does not provide those, unfortunately. But if you could amend or expand, basically what parts of the One Big Beautiful Bill Act do you feel like should be a top priority in order to really support, health technology, and I think ultimately the health of our communities, right? 'Cause when it comes down to it, we want to make sure that all of our communities are healthing, thriving where they live, and not having to go elsewhere for care, for livelihood, for workforce, any of that. So we have magic wands though for the next 15 minutes. What are we going to change?
I guess I'll take this one first. I feel like this is my wheelhouse. I don't have a federal one. I got a state one, but when I look at this overall, like if there was like one specific area that I would try to focus on, would probably be more around keeping the enhanced Affordable Care Act premiums, tax credits in place. 'Cause I think that would be like one levers that would help us soften the blow for the Medicaid cuts, the most. Because I think what the Beautiful Bill Act is kind of hedging on is that the market will react, like will overreact for the shrinking of the safety net. I think they're kind of placing a bet on the market as opposed to incentivizing performance as far as like quality of care. Like that was the one thing that I kind of favored in the Affordable Care Act, was just really placing more of the onus on what is the quality of care, value-based care. That I will probably re-modify it in those terms, less around taking all the funding away and just get better. Because I don't think that the system, like health system, patients shouldn't be in a position where they are expected to just jump in the air and we remove the step that's there that they were standing on, hoping that they get to the next one. I think more of a staggered approach where we don't necessarily just strip away all the funding, but rather just incentivize like a higher quality of care being delivered to patients.
I think one of the things that is going to happen as we move forward is that when we finally get to the point where provider tax rates are starting to be ratcheted down on states like Missouri that have expanded Medicaid, we are going to see a battle royale in Congress for obviating those cuts. And I only say this just as a point of reference, but like in the Affordable Care Act, there was a removal of a large portion of the DISH program that was supposed to go to states because states were supposed to expand Medicaid. Now, of course, a bunch of states didn't, including the state whose hospital association I represent in Kansas. They didn't expand Medicaid, and yet they were going to have the DISH cuts. And so what ended up happening, and what has become a kind of the reality in Congress, is that every time a funding bill is passed, whether it's a CR or an omnibus or an individual appropriation cycle, they end up obviating those DISH cuts for the states that didn't expand Medicaid. And this is going to turn into one of those kind of onward creaking fixes that will sort of get over leveraged over time. And there's two components to it. The one component is the provider tax rate is supposed to go down in states that have expanded Medicaid on a particular schedule down to 3.5% eventually. Then you have the state directed payment programs that are going to be reduced based off of a percentage of the rate that Medicare pays over time. And I think both of those things are going to be on the table in terms of how healthcare policy advocates are going to be thinking about how federal funds flow into states as we go forward in this. Because right now we're talking about all the money coming to the states, but we're not talking about the cuts because the cuts were pushed off to after the next election for reasons that I suppose are obvious. So once we have the cuts, though, now the question is going to be, what are we going to do about that? And I think that there's going to be a tremendous amount of support. And I think even Senator Hawley has said this the day after this bill was signed, the ink wasn't dry. He said, I'm going to work like heck to get these, to make sure that the provider tax rates never get cut. And that's a Republican. I think that many Republicans feel much the same way as him. And I think that Democrats who voted against this would probably play ball in this sense. So, I mean, I guess we'll see. I mean, I think that this is sort of the opening salvo on a reconfiguration of how federal resources are going to flow to the state.
And I just want to applaud Landon because you highlighted a lot of what's happening now and gonna happen in the near future. So, but I think I would also like to circle back because I know that there are people listening to our voices right now and will watch this recording that are contributing vitally to these conversations right now at the state level as collaborators or otherwise. So I think one thing I'd like to us to hold on to positively is the collaboration that's come out of this. Again, we're a collaborating group anyway. I've seen strong relationships over the 2.5 years I've been in this role and in the state. I'm just privileged to be here in a state that's trying to make a difference, whether it be urban or rural. I think that we are uniquely positioned with strengths that align to our representatives in DC. But specifically, I come from large integrated healthcare into my current role with more of a public health lens. And I think the access to data is what drives decisions. And accessing data is predicated on the technology to gather it and the access of the clinician, professional, provider, physician to input that data. So from my side, what do I want to see out of this is I think about those, standalone practices. I think about those standalone hospitals. I think about the technology deficit in our most under-resourced communities. And I'd really like us to close that gap a little bit because I think if we do our part at the macro level, these communities can sustain themselves. We see critical actions of the last couple of years have resulted in some wins for our most rural areas. So the question would be is how can we take those individual examples, use cases, and expand them and make our communities, under-resourced communities, more resilient? Because I just want the clinician, the provider, the physician to stay in their community. They want to stay in their community, but by the current model of care and the current support of the technology and solutions and reimbursements, they're being forced into where we're at today. So I think my dream would be just to see the technology component be solved for these, especially the standalones that I mentioned.
Yeah, and for me, if I was to bring it really to a health technology perspective, this bill is replete with encouragement to provide remote and virtual care, and yet I don't see firm incentives in there. In fact, right now, the telehealth waivers that were in place following the COVID pandemic have gone away because Congress can't come to an agreement on a continuing resolution. So we're talking out of both sides of our mouth here. So I would really like to see Congress embrace a telehealth system, promote it, incentivize it, fund it, make the reimbursement make sense, and bring virtual care to everyone, because we're a little fragmented in how we feel about telehealth at the current moment. And so seeing that all come together would be nice. The other thing I would like to see or I would have expanded from a technological perspective, is what do we do to decrease administrative burden and burnout on the providers? When you think of, providers just don't get to really see patients anymore. They're dealing with paperwork. And so I would have liked to see more incentives in here to use technology, AI, et cetera, to reduce the burden on providers and allow them to get back to just spending time with their patients.
Amen to that. That's a good way to finish it off. So, first of all, thank you all for your time. I wanted, though, to take a few minutes because we have basically three left. Are there any questions from the audience that we want to pose to our panelists with the few minutes we have left? Basically, if you want, I think put it in the Q&A or put it in the chat or something like that so that we can unmute you or work our Zoom magic to get it figured out. Let's see. Or if we don't have any questions, which, I mean, these panelists are good. I will give them that. Having no questions, though, we'll see. If not, so I think for the very end, then, with that, we can just have basically each one give like your 30 seconds of what are your final thoughts? Like, what do you want to leave the audience with around the One Big Beautiful Bill Act, its impact for our state, and how we hope it's going to either be good or bad, honestly, for health technology. So no pressure, but
Well,
whatever you got,
I'll start.
wherever
I
wants to
think if
go.
Missouri does
Bring it,
this
Jane.
right, the opportunity for strategic collaboration and to really bring the healthcare system together among providers to work more collaboratively, to be more strategic about how they follow patients through the continuum of care. There is enormous opportunity to improve that here, and I hope that we are able to do that with this funding.
And I'll just continue that with, I don't think this is the last change we're going to see in the very near term. So I do hope we can lean into these relationships and this collaboration that's going to help us succeed in this circumstance and win at the next level, because I'm convinced next calendar year is going to bring us hopefully some good news in maternal health, as well as senior care, more long-term care kind of reimbursement. So let's get ready to go win next year with the lessons we learned this year.
Perfect. Either one, Landon or Rep Murray.
Go
It's like
ahead.
a stare down. No, I'll go. Mine is quick. I mean, I think first and foremost, thank you so much for hosting this panel. It's been very rewarding for me to be a part of the discussion. The thing that kind of sits in the back of my mind that keeps me up at night is more around like with us passing this, what is the impact going to be on the patient? Like the health system as a whole is already strained to the max. And it's like for us to have to respond and react to this in such a hastened way, with the stakes being as high as they are, it's like, how do we just move forward without ensuring that there aren't massive drops in coverage for people who already are, struggling to keep up in terms of like how tough life is right now, because people aren't going to just magically stop getting sick. I mean, I think that like they were like someone on the panel mentioned earlier is like we'll just realize those costs in the emergency department. So like how do we ensure that doesn't happen is kind of what's lingering in my mind.
I just want to say that I'm really glad that this funding is out there because I think that over the next 5 years, we are going to witness profound changes in society and in healthcare driven by AI. In the first quarter of this year, I think I heard a stat that there was more private equity spent on artificial intelligence than everything else combined in the United States. And that just means that things are going to be different. I don't know how they're going to be different. We can't really predict it, but I'm glad that this funding is out there so that we can be fluid and change with the times.
Isn't that the truth? That's a good way to end it. I guess first off, if we all, I know we're all virtual right now, but give our panelists a round of applause. I can do that. At least you can hear me now. But yeah, just appreciate your time. I know it's with busy schedules, but just like Representative Murray said, I think we all learned a lot about where we are, where we're going to be, where we hope to be for sure as a state after this bill kind of gets played out in real time. But just thankful for everyone's time and just insights and to keep that partnership, to keep that mindset of, we have to work together and think differently because, the mindset we had when we developed the problems is not going to create the solution we need to make the change, right? Albert Einstein, smart man. So thankful for you all and your time. Just, I would be remiss if I didn't let you all know as well. We have our website for the Midwest Gateway chapter, our LinkedIn site, and our Facebook page. So QR code, link, what have you. We'll send this out to you all after this panel. But thank you all for your time and just looking forward to what this new year will bring.